last major conferences, ASCO, World Lung, and I will also add in a little bit of ESMO coverage. And hopefully we'll have some good discussion. There's a lot to cover, but please feel free to put any questions or comments in the chat or raise your hand, and we'd be happy to answer as we go through. So, all right, take it away.
So good afternoon, everyone. It's a pleasure being joining with you today. As Dr. Ines Menjak mentioned, I'm from Brazil, and it's a pleasure being here doing a fellowship at Lung Cancer Department. So I will start my presentation talking about the highlights from World Conference Lung Cancer presented this year in Vienna. Not going. So my presentation, I will talk about 6 abstracts. My presentation is focused on the early stage screening of lung cancer and also stage 3A to 3B. So the first presentation is about the comparison of stage and histology-specific CT sensitivity in the Nelson trial and the NLST trial. As we know, Nelson and NLST trial are both screening trials which demonstrate a reduction of mortality of lung cancer using a CT low dose in patients with high risk of lung cancer. As you can see, in the Nelson trial, the detection of early disease in stage 1A to 1B is represented in the dark blue bar with 71%, and the NLST is represented at 62% of the diagnosis of early disease cancer stage 1A to 1B. This trial, they differed from each other in terms of study population, trial design, and also the nodule management protocol. The Nelson trial showed a reduction in lung cancer in 24%, and the NLS trial reduction in lung cancer mortality in 20%. This trial has the aim to evaluate how the sensitivity of the CT scan with the nodule management protocol can affect in terms of stage and also histology. In this slide, you can see in the dark blue bar that the Nelson trial showed more sensitivity of CT scan using low dose comparing to NLST. The Nelson trial incorporate the volume to evaluate the nodule, and the NLST incorporate only the diameter. So in terms of histology and the stage, then the CT sensitivity in the Nelson trial estimated to be higher compared to NLST. So the conclusion of this study is that the volume-based nodule management may improve the potential for lung cancer mortality reduction in population based in screening programs. The next one that I think was one of the most important study presented in the World Conference Lung Cancer is a North American trial, phase 3, non-inferiority, CALGB 140503, which evaluate the sublobar resection for peripheral clinically stage 1A equal or less than 2 centimeters in patients with non-small cell lung cancer. Lobar resection has been the surgical standard of care for clinically T1 and 0 non-small cell lung cancer since 1995. Sublobar resection reserved for a subgroup of patients with marginal pulmonary preserve. However, with the newer imaging modalities, better stage screening of lung cancer and molecular tumors has been resurging an interest on sublobar resection. Recently, a Japanese trial called JCOG0802 reported that patients with clinically T1A and 0 equal or less than 2 centimeters with non-small cell lung cancer who underwent a sublobar resection was not inferior to lobectomy in terms of endpoint of overall survival. So the CALGB 140503 has a similar design from the Japanese trial, but is a North American trial, which evaluate, which compared the lobar resection to sublobar resection in patients in early stage disease of cancer of non-small cell lung cancer. Is a phase 3 randomized non-inferiority trial which locate patients with suspected or confirmed peripheral non-small cell lung cancer, T1A and 0 equal or less than 2 centimeters. These patients must meet the eligibility criteria in the intraoperative with the confirmation of non-small cell lung cancer and absence of disease at level 10 of the major mediastinal and at least 2 stations of the mediastinal. 697 patients were randomized. One arm underwent a lobectomy and the other arm a sublobar resection. The sublobar resection could be a segmentectomy or wedged resection. The primary endpoint was the disease-free survival, and the secondary endpoint was overall survival, rates of recurrency, and pulmonary functions changing in 6 months. In terms of baseline demographic and clinical characteristics, the patients were well balanced. I've highlighted the 3 stratification factors: tumor size, smoking status, and histology. And as we can see, there were more adenocarcinoma histology, but they, in terms of histology, were well balanced in the both arms, sublobar resection and lobar resection. Let's show this one. Just a minute. Sorry. Okay. And in the results from the primary endpoint in terms of disease-free survival, the sublobar resection was not inferior to lobar resection. The hazard ratio was 1.01, with the P statistically significant 0.01. Patients who underwent a sublobar resection, 58.8% underwent a wedge resection. In a median of follow-up 7 years, the tax of 5-year survival was 63.6% in the sublobar resection and 64.1% in the lobectomy. In the analysis of exploratory subgroups, the disease-free survival was not different in terms of sublobar resection and lobar resection in terms of age, race, gender, tumor location, histology, smoking status, tumor size, and performance status. In terms of disease recurrency, around 30.4% the patients had overall disease recurrence in the arm of sublobar resection and 29.9% in the arm of the lobar resection. However, the P was not statistically significant. And numerically, 13.4% of patients underwent a sublobar resection had a local regional recurrence, compared to 10% in the arm of lobar resection. However, the P was not statistically significant. The secondary endpoint of pulmonary function was evaluated by the FEV1 and FVVC. If you can look in the both arms were decremental in terms of pulmonary function. However, it was lesser degree in the arm of sublobar resection, 4, and the arm of lobar resection was less 6, and the P was statistically significant. In terms of FVVC, there is no difference statistically in terms of the decremental of respiratory function. So the conclusion of the CAUGB 1403 CAUGB 140503, patients with peripheral T1A and 0 non-small cell lung cancer equal or less than 2 centimeters without metastasis to major hilar and mediastinal lymph nodes. Sublobar resection was not inferior to lobectomy for the primary endpoint of disease-free survival or the secondary endpoint of overall survival. The disease recurrence was approximately 30% without significant difference between the arms. And although the absolute difference in the magnitude of reduction in pulmonary functions favor the sublobar resection arm, it may be not clinically meaningful. So the results from the CAUGB as the JCOG 0802 established sublobar resection as the standard of care for this subgroup of patients. Next study is about adjuvant treatment with atezolizumab. In the last year at ASCO was presented the disease-free survival from Empower 010, and this year Dr. Enriqueta presents the overall survival interim analysis from the Empower 010. The EMPOWER-010 is the first trial, phase 3, that evaluate that adjuvant treatment with atezolizumab after resection in non-small cell lung cancer who underwent a platinum-based chemotherapy and showed a statistically significant benefit in terms of disease-free survival for patients with PD-L1 equal or over than 1% in stage 2 to 3A the population. The hazard ratio was 0.66. It was statistically significant, and based on this find, atezolizumab was approved as a adjuvant treatment after resection and platinum-based chemotherapy in patients with PD-L1 equal or over than 1% in countries as USA, China, and Japan, and for patients with PD-L1 equal or over than 50% in Europe, other countries as in Canada. However, I think in the Ontario, the approval is not authorized yet. Here in this presentation, Dr. Enriqueta present the first pre-specified interim analysis of overall survivor at a median follow-up of 45.3 months. The design of the EMPOWER-010 is a phase 3 clinical trial. Patients who had completely resected stage 1B to 3A non-small cell lung cancer must have stage 1B tumors equal or over than 4 centimeters, ECOG 0 to 1, underwent a lobectomy and PD-L1 analysis. These patients received 4 cycles of chemotherapy based on platinum, and then they were randomized. 105 patients were randomized. One arm received 1,200 milligrams of atezolizumab each 3 weeks for 16 cycles or 1 year, and the other arm was the basic support care. The endpoint primary was the disease-free survival that was evaluated hierarchically. Sorry. The disease-free survival is the PD-L1 equal or over the 1%, stage 2 to 3A, and if the population and if the disease-free survival was positive, then they was evaluating the all randomized population, and if it's positive, the disease-free survival was tested in intention to treat population, stage 1B to 3A, and if it's positive, the overall survivor was evaluated in the intention to treat population. So the results from the interim analysis of overall survivor in patients with PD-L1 equal or over than 1% stage 2 to 3A demonstrate a tendency of overall survivor favoring the arm of atezolizumab. The hazard ratio was 0.71, although it was not statistically significant. The overall survivor appeared trained to be favored in the arm of atezolizumab. The 67.8% of overall survival in the arm of atezolizumab and 67.5% in the arm of the basic support care. When the overall survivor inter-analysis was evaluated for all randomized and intention to treat population, we didn't see a statistical benefit in the arm of atezolizumab. In the randomized population, stage 2 to 3A, the hazard ratio was 0.95. Which be not statistically significant, and also in the intention to treat population. When the overall survivor was evaluated by the biomarkers status stage 2 to 3A, we see a significantly clinically meaningful significant benefit in terms of the high expression of PD-L1. As we can see, when even with the EGFR and ALK including, the hazard ratio was 0.43 in the arm of the PD-L1 in patients with PD-L1 equal or over than 50%. And when they exclude the patients with driver mutation, the benefit maintained with a hazard ratio 0.42. So in 5 years, 84.8% of patients in the arm of atezolizumab remains alive, compared to 67.5 patients in the basic support care. So the conclusion of this interim analysis is that the overall survivor trend in favor of atezolizumab was seen in the PD-L1 equal or over the 1% stage 2 to 3A population. The hazard ratio was 0.71, interval confidence 0.41 to 1.03 at the time of the first pre-specified interim analysis overall survivor analysis. These data support that the previous report positive benefit risk profile of adjuvant atezolizumab in PD-L1 positive resected non-small cell lung cancer and contribute to evidence supporting standard of care use. The Empower 010 will continue to the final analysis of disease-free survivor and further evaluation of overall survival. In the setting of stage 3 unresectable non-small cell lung cancer, I brought the first trial, Dolphin trial, which was a phase 2 and a Japanese trial. In this case, the durvalumab, as we know, is the standard of care immunotherapy consolidative after concurrent chemoradiation in patients with unresectable locally advanced cancer, non-small cell lung cancer. However, about 25% of patients are unable to receive durvalumab due to side effects or poor performance status by concurrent chemoradiation. So this study is a phase 2 and single arm, was the first trial that evaluated the efficacy and safety of durvalumab plus concurrent curative radiation therapy for PD-L1 positive unresectable locally advanced non-small cell lung cancer without chemotherapy. So the study designed the primary registration, patients who has suspected of lung cancer, non-small cell lung cancer, unresectable stage 3 or postoperative recurrent with a COG 0 to 1. Then they underwent a secondary registration, and the eligibility criteria must confirm one resectable stage 3 non-small cell lung cancer or postoperative recurrence. They accept patients with postoperative recurrence. It was about 25% of the patients, and the PD-L1 equal over the 1%. 35 patients received the radiation treatment with 60 grays of radiation and durvalumab 10 milligrams per kilo each 2 weeks for up 1 year or unacceptable toxicity. The sample size calculates the threshold of the 12-month PFS rate, 28%, and expected rate of 50%, and the primary endpoint was 12-month PFS rate assessed by independent central view. In terms of baseline characteristics, the median age was 72 years old. The majority of patients were male with 88%. Smoking history, stage 3A represented by 45% and stage 3B 20%. 7% received the radiation, and the primary endpoint 12-month PFS rate was 72.1%. Higher than the expect, that was 50%, in the median of follow-up 12.7 months. So the Dolphin trial is the first report of durvalumab combined with curative radiotherapy for PD-L1 positive unresectable locally advanced non-small cell lung cancer with good performance status. The primary endpoint of 12-month PFS rate was met and much higher than expected value. And it suggests this strategy of treatment is promising with tolerable side effects and appropriate as a study treatment for phase 3 trials. Another question regarding the stage 3 unresectable non-small cell lung cancer is about the duration of consolidative immunotherapy. In this case, as we know, around 40% from the patients from the Pacific did not complete the full year of the consolidative immunotherapy with durvalumab due to side effects or other reasons. So this study, a phase 2 study of consolidation immunotherapy with nivolumab and ipilimumab or nivolumab alone after concurrent chemoradiation for patients unresectable stage 3 to B non-small cell lung cancer, evaluate the immunotherapy consolidative for 6 months, as I highlight in this slide. So patients unresectable stage 3 to B non-small cell lung cancer, they received the concurrent chemoradiation, and then they were randomized. One arm received nivolumab for 180 milligrams each 4 weeks, comparing to the history control of concurrent chemoradiation alone, and the other arm received nivolumab 240 each 2 weeks, plus ipilimumab 1 milligram per week each 6 weeks for 6 months, comparing to the results from the Pacific. So in terms of characteristic patients, the median age was 65 years old. The majority of patients were male. It was imbalanced in the two groups. In nivolumab was 44%, and the other nivo and ipi 56.9%. In terms of chemotherapy regimen, the majority of patients received carboplatin and paclitaxel. The results show there is no difference in terms of nivolumab alone or nivolumab and ipilimumab as an option for consolidative immunotherapy. This study was not, the man was not compared the nivolumab alone to nivolumab and ipilimumab. It was not a head-to-head comparison, but they show, and this study showed that the PFS in 18 months, which was the endpoint, the primary endpoint, was around 65% in the both arms, and the overall survival in 18 months was around 80%, with 82% in the arm of nivolumab alone, and nivolumab and ipi 85.7%. So the primary endpoint was the PFS in 18 months. So this strategy of treatment was reasonable with only 6 months of consolidative immunotherapy, independent, regardless if it was only with nivo alone or with the combined immunotherapy. In terms of side effects, as expected, the combined arm showed more side effects, mainly in pruritus and diarrhea and pneumonitis, which in the grade 3 we could see 70.6% of grade 3 pneumonitis in the arm of the combination. So, but however, the most patients with pneumonitis recovered quickly with steroids. And the conclusion of this trial is that the nivolumab alone after concurrent significantly improved the 18 months PFS over historical control, and the combined nivo and ipi after concurrent chemoradiation also improves the 18 months PFS over historical control from Pacific. So the both arms demonstrate a promising PFS and overall survival despite only 6 months of consolidation treatment. The next study, Gemstone 301, also for this subgroup of patients unresectable stage 3 non-small cell lung cancer, evaluate the sutimlimab over placebo after concurrent and also sequential chemoradiation treatment for this patient. The Gemstone is a Chinese trial which was published at the beginning of this year and demonstrated a significant benefit of disease-free survival for patients who received the sutimlimab. In this presentation, they show the final analysis of PFS in the Gemstone 301. So this study was the first study that includes patients who underwent a sequential concurrent chemoradiation, because as you know, in the Pacific, only patients underwent a concurrent chemoradiation was randomized to receive durvalumab. And this study was the first one that includes sequential chemoradiation in the patients who received the sequential treatment. The sutimlimab is an anti-PD-L1, and in June of this year, China approved the sutimlimab as an option for treatment in unresectable stage 3 non-small cell lung cancer. And this presentation, I report the up-to-date results from the final PFS analysis. So the study design is a phase 3 patients with unresectable stage 3 non-small cell lung cancer whose disease was not progressed following concurrent chemoradiation or sequential chemoradiation, ECOG 0 or 1 to 1 with no driver mutation, were stratified to receive one arm sutimlimab and the other arm placebo. 381 patients were randomized. In the arm of sutimlimab was administered 1,200 milligrams each 3 weeks, and the arm of placebo in the other arm placebo, both up to 24 months. So different from the Pacific trial that was only 1 year. The primary endpoint was PFS, and the secondary endpoint overall survival. PFS by the investigators according to the RECIST, overall response rate, duration of response, time to death, and safety. In the demographic and baseline characteristics, I highlight that the majority of patients had histology of squamous cell carcinoma with around 70%, and 1/3 of patients received the sequential concurrent chemoradiation. So the majority of patients in this trial received concurrent chemoradiation. The PFS, the final analysis of PFS met the primary endpoint with a hazard ratio 0.65 and P statistically significant. The median of overall survival was 10.5 months in the arm of sugemalimab and 6.2 in the arm of placebo. When they evaluate separately the sequential chemoradiation, the concurrent chemoradiation, the benefit of the sugemalimab in terms of disease-free survival remains, with hazard rate of 0.57 in the arm of in people who underwent sequential treatment and 0.71 in the arm of concurrent chemoradiation. I highlight the numbers numerically. In the arm who underwent concurrent chemoradiation was the median of overall survival was higher with 15.7 months, and the sequential treatment 80.1 months. So the conclusion of this gemstone trial is that the PFS final analysis should show the sustained improvement in disease-free survival with sugemalimab compared to placebo in patients unresectable stage 3 non-small cell lung cancer who had not progressed following concurrent chemoradiation and sequential chemoradiation. The preliminary overall survival data show the trend for benefit favoring sugemalimab. Similar overall response rate in the both arms was around 25%, and the duration of response was higher in the arm of sugemalimab versus placebo with 24 months, and no new safety signals were found in the PFS final analysis. In the last abstract that I will present was the NADIM-2 trial, which is a phase 2 randomized trial. In this presentation, Dr. Provencio, he presents the secondary endpoints in PFS and overall survival from the NADIM. Because in the first moment it was published the NADIM-1, which was a phase 1 trial, phase 2 trial, a single arm, that evaluate the combination of nivolumab plus chemotherapy in patients resectable stage 3 non-small cell lung cancer. The historical reports from this article showed a benefit in overall survival and also disease-free survival, and an improving percentage of patients with pathological complete response, which was around 60%. Then after that was published the Checkmate 816 trial, which was a phase 3 that also showed improvement median event-free survival and PCR. The NADIM-2 phase 2 was a randomized trial with 2 arms that compared the neoadjuvant nivolumab and chemotherapy to chemotherapy alone in patients resectable stage 3A to B non-small cell lung cancer. In the primary endpoint, which was a pathological complete response, shows that 36% of pathological complete response. And in this presentation, in the World Conference Lung Cancer, Dr. Provencio presented the secondary endpoint of PFS and overall survival at 24 months. The study design was a local patients with non-small cell lung cancer, locally advanced, potentially resectable, stage 3A to 3B, according to 8 edition and no driver mutation. They were randomized. One arm received nivolumab, carboplatin, and paclitaxel for 3 cycles, and the other arm carboplatin and paclitaxel. After that, 42 to 49 days, these patients underwent a surgery, and in the arm of experimental arm, they also received adjuvant treatment for 6 months with nivolumab. The primary endpoint was PCR. The secondary point was PFS in 12, 18, 14 months, and overall survival in 12, 18, 14 months. 24 months, sorry. In the baseline characteristics, I highlight that the majority of patients had disease in the mediastinum, around 70%, and half of them had multiple compromised station in the mediastinum. 93% of patients in the arm of the combination nivo and chemo had a definitive surgery, compared to 69% in the chemotherapy arm. The resection R was 92.5% with resection R0 in the arm of the combination, 65% in the arm of the chemotherapy alone. So the PFS survivor at 24 months was met as a secondary endpoint, showing it was not reached, and the hazard ratio was 0.42 with P statistically significant. 66% of patients were free of progression disease in the arm of nivo and chemotherapy, comparing to 42% in the arm of chemotherapy alone. In terms of overall survival, the benefit was seen with hazard ratio 0.40, clinically statistically significant, and the median of overall survival was not reached, with 84% the patients alive in the arm of the combination. Patients who had a complete pathological response remained alive free from disease progression, comparing to patients who had incomplete PCR. So the conclusion of the NADIM trial is that NADIM-2 confirmed the superiority of neoadjuvant nivo and chemotherapy combination in patients with resectable stage 3A to B in non-small cell lung cancer. And also the NADIM-2 is the first trial which neoadjuvant immunotherapy based in nivo and chemotherapy for resectable stage 3 to B show improvement of overall survival. That's it. Thank you.
So we're just gonna switch. Just bear with us for a sec. We're gonna stop this and open. Okay. So now we're going to switch gears a bit and talk about the advanced setting. So we're looking at both non-small cell and small cell. So I'm going to so I just wanted to highlight a couple of the underlying studies here that I think may be practice changing. So we're looking at the group of patients with PD-L1 greater than 50%. We'll talk about this study. There is also for something new for the patients post progression on IO with her, with chemo or sequential. Highlighting this study, which is a phase 3 of sotorasib for patients with KRAS, as well as another phase 2 study. Patients with EGFR mutations, we had some phase 1 and phase 2 studies presented at the various conferences that we'll go over. There was a study we may not get to today, but it was looking at atezolizumab with chemo for brain metastases without radiation. And then another phase 3 study that unfortunately was not a positive study for small cell. So for the patients with high PD-L1, the FDA did a pooled analysis, which was presented at ASCO. So first line treatment options for patients with high PD-L1 in the first line setting includes monotherapy with immunotherapy, but also the combination is approved and proven. The control arms of those studies that looked at the combination included just the platinum-based chemo. They did not compare to immunotherapy alone. And it's unclear if chemo does substantially improve outcomes in this particular patient population. So the FDA set out to try to make that comparison. And they did that using a pooled analysis from 12 randomized trials. They looked at OS, PFS, and ORR, so objective response rate between the two groups. They adjusted for important predictive factors and excluded patients with EGFR and ALK mutations. So they had over 3,000 patients included in this analysis, most of which were under 75 years of age, most of which were male and white. the median overall survival was actually not significantly different for this population. So the hazard ratio was 0.82 and crossed the boundary. For PFS and response rate, it did seem to be higher with the chemo IO combination. Whether that's clinically significant, is debatable. One of the subgroups that was discussed was that subgroup of patients that were over 75. And if you look at this chart, you can see that the overall survival, the PFS, and the response rates really did not, they were actually worse with the combination. So it didn't really pan out for those older patients, which is not particularly surprising given the increased rates of toxicity with combination. Now, this analysis did not examine toxicity or safety. They also didn't comment on subsequent treatments. So the authors concluded that for patients with PD-L1 scores of 50% or more, these combination regimens may have comparable, survival with monotherapy, and the PFS and the response rates were better with the combination. For those who were 75 or older, they did not see improvements. So as I mentioned, those other factors were not assessed. And I think it highlights the fact that we need to select patients appropriately for their treatments. Typically, at least in our center, for these patients that are 50% and higher, we're treating them with monotherapy, which I think is appropriate. So in the space, this difficult space is sort of third line or quasi third line now, post-immunotherapy and chemotherapy. There was a new study that was presented at ASCO and also published simultaneously in JCO. This was the Lung Map trial. Now, this study was combining a VEGF receptor blocker, which is called ramucirumab, with pembrolizumab. They did not select based on PD-L1 status of these patients. All of them had progression on a checkpoint inhibitor as well as a platinum-based chemo, either together or sequentially. They needed to have some, at least initial response to the checkpoint inhibitor. As you can see, I've underlined, they had to progress at least 84 days after the start of treatment with their checkpoint. And so the hypothesis, which is what I certainly, which I find interesting and promising, is that, they think that the VEGF blocker might overcome some resistance to immunotherapy by reducing tumor neovascularization with upregulation of pro-inflammatory cytokines. So I think it's an important concept to study. So this was a phase 2 study. They had 130 patients. They were randomized to investigators' choice of standard of care versus the pembro plus ramucirumab. Now, I want to highlight, if you can notice the list of standard of care, the first one there is docetaxel ramucirumab. This is standard of care outside of Canada, but we don't have approval for this. We don't use this. It's based on a study called REVEL, which was published a number of years ago, using docetaxel ramucirumab. They did have, fairly high rates of toxicity, and from what I double checked on the Canadian regulatory websites, it was never actually even submitted. Like the company did not submit for approval here. So we tend to use docetaxel in this setting most often. Now I'm highlighting that because if you look at their study, the majority of patients in standard of care were docetaxel plus ramucirumab. Only 3 of them had docetaxel. So not exactly applicable to our practice, but still, I think, important and proving a concept here. So the primary endpoint was overall survival. So the overall survival data showed a benefit, statistically significant benefit for this, which was 14.5 months versus 11.6 months, hazard ratio of about 0.7. The progression-free survival was not statistically significant, and numerically it was about 1 month. Just wanted to highlight for the subgroups that the benefit did not appear to vary by PD-L1 expression. This was taken from the JCO publication. I know it's a busy slide, but just to highlight the main grade 3 toxicity with ramucirumab pembro. Most common was hypertension, which is related to the Menjak. There were 4 treatment-related deaths, but they were on the standard of care arm. So the authors concluded that ramucirumab pembro improved overall survival in this pretreated population compared to standard of care. And I think most interestingly is that, of course, this is suggesting that the modulation of the immune microenvironment with an angiogenic agent may help resensitize tumors to immunotherapy. And I think that's an area of interest, and certainly further evaluations warranted for this phase 2 study. So KRAS G12C, there's a couple of studies presented. This one I snuck in, it was actually from ESMO, but I think it's important. I think it will hopefully change practice for us. So this is looking at sotorasib versus docetaxel for patients with KRAS G12C mutation. These are patients who were previously treated. KRAS mutation occurs in about 14% of non-small cell lung cancers. So sotorasib is an oral irreversible KRAS G12C inhibitor. In the early phase code break study, it certainly had a promising response rate of 41% and PFS of 6, an OS of 12 months. Docetaxel has been really the preferred option in this space, as I mentioned before. And these are the response rates and PFS, which are not particularly impressive, but some retrospective data suggests that these numbers may be improving in the context of previous immunotherapy. So this is a phase 3 study of this inhibitor, sotorasib, compared with docetaxel. Patients had at least 1 prior treatment, including a platinum-based chemo and a checkpoint inhibitor, no active brain mets. They were randomized to sotorasib versus docetaxel. Primary endpoint was PFS. Crossover was permitted. So the baseline, just to highlight that the majority of patients here, have 2 or more lines of therapy. So their primary endpoint was statistically significant. So at 12 months, the PFS rate for sotorasib was about 25% versus 10% docetaxel. The actual medians were 5.6% versus 4.5%. The hazard ratio is 0.66. The overall survival was not powered for, didn't show a significant difference. And just to highlight, there was crossover, significant, proportion of patients here, over a third, had crossover to a KRAS inhibitor in the docetaxel arm. So the safety profile in general favors sotorasib with fewer grade 3 and higher AEs. Most common grade 3 plus toxicities with sotorasib are GI related, with diarrhea and elevated liver enzymes, nausea. Patient-reported outcomes also favored sotorasib with delay in time to deterioration of symptoms and quality of life and functioning. So I think we're quite pleased that there was a significant improvement in the PFS. The 12-month rate, was more than doubled PFS, hazard ratio 0.66. No significant difference in OS, but there was obviously more than a third of patients in the docetaxel arm crossed over to KRAS inhibitor. So I don't think we're particularly concerned about that, and it seems to be fairly well tolerated. So I think this will be a good option for a number of patients. We do have to mention the other drug that was talked about at ASCO was also published in New England at the same time. It's called adagrasib. And the authors mentioned that it has some pharmacologic differences to sotorasib in terms of a longer half-life, and there's seems to be potential for CNS penetration that has been demonstrated. Even though I know that sotorasib has had high rates of stable disease in the brain, but I think adagrasib is sort of trying to, at least they have proved that there is some CNS penetration in this setting. So in this setting was a phase 2 cohort of a non-randomized trial, and they put patients who were previously treated with immunotherapy in combination or sequence with platinum-based chemo, treated with adagrasib, and their primary endpoint here was objective response rate. Just to highlight, about 20% of patients had CNS Mets. So we had a number of patients here responding with shrinkage in their tumor with a disease control rate of about 80%. Their post hoc analysis for the intracranial response showed about a third of patients with response intracranially, with the duration lasting over 11 months. So the PFS and OS, which are the secondary endpoints, over a year for PFS, about almost 16 months for OS. Again, showing the typical GI toxicity similar to sotorasib. So in conclusion, they're looking at moving into, or they're doing a phase 3 trial to compare this with docetaxel, and seems to be promising with the response rates. So in the interest of time, we're going to kind of jump to the EGFR and MET. So amivantamab is a drug that's being studied in the Chrysalis sort of series of trials, was discussed at ASCO and World Lung, with actually at least three presentations that I'll touch on, all of which were sort of earlier phase studies. So not going to see this in practice at the moment, but certainly promising. So we're looking at a combination of amivantamab and lazertinib for these patients who previously progressed on osimertinib and chemo. So amivantamab is an antibody for EGFR as well as MET. Lazertinib is a third generation TKI similar to osimertinib that works against the T790M, and it has some CNS control. So they're looking at a cohort of patients with EGFR, the typical EGFR mutations who progressed, as I mentioned. They were given amivantamab and lazertinib in a single non-comparative expansion of phase 1. And their primary endpoint was overall response. They did have a number of patients with brain metastases. The overall response primary endpoint was about 33%, clinical benefit rate almost 60%, and the overall survival at this point was approaching 15 months. And this is a pre-treated population. And then of the patients with untreated brain metastases who had a follow-up scan, 26% of those had complete CNS lesion clearance. So that's promising. The main toxicity with amivantamab seems to be infusion reactions, most of which are grade 1 or 2. Pneumonitis occurred in about 7% of patients. So promising, and certainly phase 3 studies ongoing for this combination. Waiting for time. So because this amivantamab also has affinity for MET, actually higher affinity for MET than EGFR, there's another cohort of this similar study, Chrysalis 1, that was discussed at ASCO. And I just want to highlight very quickly that in this small cohort of 55 patients, we're seeing good clinical benefit rates of patients who also had prior MET inhibitors. So almost 60% clinical benefit rate for patients receiving monotherapy with amivantamab, which is encouraging. Chrysalis 2, another cohort, small number of patients, 20 patients. They received the combination of amivantamab, lazertinib, but also with chemo. These were patients who progressed on TKIs only, so they had not received any chemo. This, just to highlight, their overall response rate was 50%, clinical benefit rate 80%, and it was the same for patients who had brain mets. So I think good news for patients with brain mets from these early results. I'm going to skip this one, but just to say that there is a combination of osimertinib with platinum-based chemo. It was done in a phase 2 setting, very high overall response rates, and early sort of, PFS OS promising. Certainly toxicities in keeping with chemotherapy that we'll need to watch out for, but we will be seeing phase 3 for this study. I want to talk briefly about this study looking at brain mets, because I think it's an important population here that we don't have a lot of good answers for. So these are treatment naive patients with brain metastases of any PD-L1 status. They were treated with atezolizumab. So in this study, they received atezolizumab with chemotherapy, and they did not have any sort of upfront radiation or surgery. They did not include patients with leptomeningeal disease. They did not include patients who had mets in the brainstem or other, like midbrain, pons, etc. They could not have any obstructive hydrocephalus. They couldn't have any hemorrhagic mets. So a fairly safe group of patients. I could not find any restrictions listed about number of mets or size. I don't have a final publication for this, but I did my best to search that out on the clinical trials website, etc. Couldn't find it. So these patients received the chemo for 4 to 6 cycles in combination with atezo, followed by maintenance with atezo and pemetrexed. So baseline characteristics, just to highlight, the median number of brain lesions per patient was 5, with a range from 1 to 20. More than half of them were already on corticosteroids. They had to be receiving 4 milligrams or less of dexamethasone as part of the study. So they were talking about the median number of cycles here. Median number with the up to the maintenance would be 8 with pemetrexed atezo. Treatment-related AEs, grade 3 to 4 was fairly high, 70%. They focused on neurologic AEs. The only grade 3 AE here was seizure. The response rates. So objective response rate systemically was 45% and intracranially was about 43%. So these were concordant, except in a few patients, and did not differ based on PD-L1 expression. So in this update, they showed the PFS systemically was 8.9, intracranially 6.9 months, and the overall survival was approaching 1 year. And PD-L1 status and dexamethasone didn't have any significant effects on the overall survival. This was interesting. So the post-hoc analysis looked at the time to brain radiation. So for this group, any brain radiation was received in 60% of patients. And of those, most of them were actually whole brain radiation. So I'm not sure, we would like to see the full data on this to see why they receive whole brain radiation, particularly at our center. We have excellent techniques and staff who are very experienced with the stereotactic techniques. So I'd like to see the data on why they had whole brain and whether we would have done the same. So we'll wait for that publication. But so I think promising in the sense that we're seeing, clinical activity in these patients with untreated brain mets with a good intracranial response rate. It doesn't seem to be affected by PD-L1 status or, receipt of steroids. Okay, we have a few more minutes left. So this, I think, is my last. So I didn't want to leave out small cell, but there was nothing really practice changing. But there was a good phase 3 trial for extensive stage small cell first line. with adding a TIGIT antibody to one of the existing standard of care, which is atezo plus carboetopicide. So first line atezo, obviously, with chemo is one of the accepted standards of care based on Empower 133. TIGIT, if you haven't heard of it, it's another inhibitory immune checkpoint, and it's there are targets that have been developed for this, like tiragolumab, and they studied this in the Skyscraper 2 phase 3 trial with primary endpoints of OS and PFS. So they randomized patients to receive the standard of care with tiragolumab versus standard of care with the placebo. And then they went on to have maintenance after 4 cycles with tiragolumab plus atezo or with placebo plus atezo. And they continued that until progression or toxicity. So these were their primary endpoints. So PFS, no significant difference. Same for OS, basically hazard ratios of about approximately 1. So nothing major for small cell, but certainly some encouraging phase 2 studies for patients with the other sort of subsets of lung cancer in the metastatic setting. So in summary, we've had a number of studies, certainly phase 2 studies that are showing promising results. In the coming years will be phase 3. And currently we had 2 potentially practice-changing phase 3 trials that were presented. So the CALGB study looking at sublobar resection for peripheral lesions that were T1A and 0, less than 2 centimeters, showing that sublobar was not inferior to lobectomy for DFS and OS. The other phase 3 study was sotorasib, showing improved PFS compared to the standard of docetaxel in pretreated patients with KRAS G12C, which make up about 14% of our patients. So we are certainly excited about this, and we have a couple minutes left for any questions or discussion. Thanks so much for your attention. And thank you to Tati for your hard work.
Thank you.
Any questions at all? Comments?
I have a question, Ines. Thanks for doing that. That was a great summary for non-medical oncologists.